So because we're operating under public meeting law, we technically need five for a quorum, so we got to wait for somebody to walk in. As soon as they walk in, we'll go. But I don't know. Is Josh sitting out there somewhere? No. I don't know if you can do this like a non-profit.
Recording in progress.
So here we go. Good morning, everybody. We got quorum now, so we'll call the March meeting to order. For the record, there is official notice here at the desk. Also on the north wall in the white fold is a copy of the open meetings law if anybody wants it. And with that, we will have roll call. You got it.
Here.
Here.
Here. We'll go to item 2 is approval of the minutes from the month of February. Is there a motion?
So moved.
Motion by Weiss is the second.
Second.
Second by Wilkin. Roll call.
Abstain. Or do I need it?
Yes.
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 Item 3 is public comments. Opportunity for anyone to comment on items related to the Board of Health that are not listed on the agenda. Again, these are for items that are Board of Health related but are not listed on the agenda. Are there any public comments at this time? And looking online, seeing none, we'll go on to item 4, which is approval of the action items for this month. We have items A through G. Does anyone need anything removed? Hearing nothing, is there a motion to approve items A through G?
So moved.
Motion by Weiss, is there a second?
Second.
Second by Wilkin. Roll call.
Yes.
Yes.
Yes. Item 5 is the report from the director, Dr. Hughes. Good morning.
So, as you know, a lot of those works have been moved to the Google Drive, so the personnel report should be there as well for you to see. I do have one recognition that I would like to bring up this morning, and then one introduction. So, my recognition, the individual was not able to attend this morning, but I want to recognize Christine Stewart, who is our lab scientist for air pollution, and she has been here for 20 years. Everybody up to date on, wow, that got loud all of a sudden. That's quite all right. We're just very grateful that we have the ability to keep the community safe and informed as to what's happening with our air quality, and she is a big part of that as our lab specialist. So, Christine, thank you for everything you do for Douglas County Health Department. And then I have an important introduction that I would like to make for you today. We have finally been able to hire our health equity epidemiologist, and I believe he has a really unique background and skill set that is going to be very useful and just very helpful to the department and to the community. And so I wanted to allow Jamin Johnson, our health equity chief, a few moments to introduce to you our new epidemiologist.
Hi, members of the board. I'm Jamin Johnson, the Chief of Equity and Planning at the Douglas County Health Department. I'm really excited to be able to introduce today Akshay Selvakumaraj. He is the health equity epidemiologist. I know that we've been waiting quite a while to have him in place. I'm super excited that he's here. I'm excited for the background that he has and the experience and passion that he brings to the job. And so I'd love for him to be able to just give you a very brief hello.
Howdy, everyone.
Akshay. I'm really excited to be here. Came all the way from Texas. So I'm getting a little adjusted to the cold, but I have a lot of background working with underserved communities and really kind of bridging the gap that we kind of face in healthcare today. And I'm really excited to work with Jamin and the rest of the team to kind of get that work done here in Omaha. Thank you.
How long have you been here now?
2 weeks.
Okay.
He brought the colder weather back to us, so
All right.
we're grateful for that.
All right. And I believe next is a COVID-19 report. And I don't have a lot to report to you in terms of what's happening here in the community, as we've been fairly stable. We have our ups and downs. But I have been promising you a new dashboard. And while it's not quite ready for prime time, I did want to demo it for you briefly. And it's very COVID-19 heavy. So I have our Chief of Epidemiology here, Justin Frederick, and I am going to have him go ahead and walk through that just briefly for you so you can see what you should be able to expect in coming months. The project is taking a little bit longer than we expected just because as we have opened up the project and added new things, it's taking a little bit longer, and hopefully it's going to be a really great tool for us going forward. So, Justin?
Good morning, everybody.
Good morning.
So the dashboard, we continue to work on it, but I think there's some really great improvements that I wanted to share with you this morning. It is taking a little bit longer than we had anticipated. Part of our infrastructure funding that we received, we're actually going to be hiring 2 internal GIS folks just for the health department to work on health data. And we're looking at creating a more robust health data section. So hoping that will help because the data, our health department collects a lot of primary data, and we'd like to change the way that we visualize that for our community. But this is the homepage where you will land on COVID-19. And remember, we're going to be doing 3 respiratory illnesses so that we have a better way of tracking those throughout the influenza, COVID, if you will, and RSV seasons. And that kind of came to light after the tridemic that we had this year with those 3 illnesses. You can see on this page that we have the 7-day total number of cases per 100,000. And on the bottom here, we actually have a little indicator now, this little red arrow, which will tell you whether or not we've seen an increase in that number from week to week. We have the 7-day total number of cases, and then we have our percent positive. The percent positive we may not be able to continue reporting after the COVID emergency is declared over. Laboratories will not be, they won't have to report negative tests anymore, so it's going to be hard for us to calculate that percent positive, but we'll continue to monitor that. The bottom we have the 7-day total number of cases per 100,000 since the beginning of the pandemic, so you can kind of see year to year. And then we do have the community level on here. And remember, there's the community level, or you can say transmission level, and then we also have the risk level. And there have been several individuals in the community that have asked us to put the risk level on the dashboard as well. That's used for healthcare facilities, mostly to determine mitigation measures. We are going to put that on the hospital tab of the dashboard because it is a little bit confusing. Our risk level is high, but our community level is low. And I don't want people to land on this page and be confused about what that means.
Jeff?
Yeah.
One thing, on the lab reporting, is there a lot of difficulty reporting the negatives on the positives?
Turn your mic on.
Oh, sorry.
No.
Is there a big difference in reporting the negatives versus the positives? I mean, is that something we can just request them to continue to do, or is it? I don't know how long it takes them to enter the data and send it.
A lot of it is it's automatic process now, so they're reported through electronic laboratory reporting. Most reports, though, we don't require that you report negatives. I'm hoping that they just continue to do that, and we can have some discussions to ask them to voluntarily do it. but it's not something that we can require moving forward. Just like all of our other communicable diseases, we switched to annual reporting, and you can see on this page that we have the COVID test performed is our first graph here. 2023 is this black line here down at the bottom, and you can compare it to the last 3 years. Positive COVID tests, the COVID percent positive, and then COVID-like illness from emergency departments, which I think is going to be a really important indicator as we move forward. And less people are being tested, just like wastewater, we can monitor viral concentration, and we can look at variants and such from wastewater. And mentioning wastewater, we are going to be adding that to the dashboard. I think, like I said, it's going to be an important measure moving forward as we have less human specimens or clinical specimens that we can subtype. So the next two tabs are probably, age group and race. I think you're gonna really appreciate. We switched these from just totals or cumulative counts to rates. And I think that's important. In the beginning, we didn't do that with race ethnicity because our laboratory data with race ethnicity, we only were receiving about 30% of that data. We're now about 70 to 80%, so much more confident in being able to report that, and I think this is going to be a much more useful indicator for the community. So this is age group, and remember, the reason that we use rates is because it's really a
Justin,
meaningful. Yeah,
Are you sharing your screen? 'Cause
I
I'm
am.
not seeing it on the Zoom.
Sorry, everybody
And I
who's
don't know if
online.
everybody else can see it.
These virtual meetings, we're all still getting used to it 4 years later.
No, but I'm seeing it on, I don't know if it's YouTube, but now it's on Zoom. It's on Zoom now, so I
You see it? Okay.
Yeah, on Zoom.
So
So
for
people
everybody
on Zoom
who
can see.
is online, this is our landing page or our summary year to date. And then this is our age groups, which I was just starting to explain. We switched to rates. And the reason that we use rates is because it's a more meaningful way to compare disease frequency between populations of different sizes, right? So what's really interesting is you can see here, in the beginning of the pandemic, it was really those older individuals, 80 and above. So you can kind of tab over these and see with each variant which populations were really most affected. This tall one here is actually Omicron. And what I found interesting here is it was 18 to 34-year-olds that were really the biggest burden of disease, and probably those that were spreading it in the community, then 35 to 49, and so forth, and 12 to 17. So much more younger population was being affected. And if you come way down here, you can see our 80 and above. And that might be because during this time we were doing a really great job of providing immunizations or vaccination for older residents in the community. More recent though, you can see that our 80 and above are spiking again, and we're also seeing that in our long-term care facilities, the number of cases and the number of outbreaks that we've been having. So I think this really drives home the point of make sure that you're up to date on your vaccine and that you've received your boosters. Gender is about what you'd expect, no real difference there. But this is where I really was struck yesterday when I was looking at this. If you see, this purple line is Native Americans or Native Alaskans, and they were really disproportionately affected throughout the pandemic. Now their denominator is small, so that's why we have so much variation, but it still doesn't take away from the fact that they were disproportionately affected. You can also see that Asian Americans have been disproportionately affected, definitely during Omicron, Hispanics, and Blacks. So I think this is really important information. We knew a lot of this, even though we weren't receiving a lot of this race ethnicity data from the laboratories. It is one of the reasons, if you remember in the beginning of the pandemic, we're working closely with our federally qualified health centers to make sure that we had testing in South Omaha. because a lot of the packing plants were heavily affected. So we had a large Hispanic and Asian population that was being affected at that time. So we stood up testing sites there and tried to respond as best we could at the time with what tools we had.
Okay, just refresh me. So that right there, that is early at the beginning, and that was when the outbreak was early. That was like the high spread for Burmese, Latinos, and the meatpacking
Correct.
industries. Then I'm trying to and you would think you would have this by heart. I'm just trying to make sure. Then the next big spike, that was around November, still in 20, and that was when the city did the mask mandate around in there. Then it went down June. Then the last big spike is when
This year.
the health director's mandate. That's it. Okay. No, I'm just trying to make sure.
This is
okay.
the
That's
big
that's
Omicron spike,
Okay.
yeah,
All right.
when
All right.
the mask mandate
All
was
right.
instituted or reinstituted.
Yep.
I think it's really interesting. I mean, as you look at this, I'm hoping that once we release the dashboard, that it better serves our population to kind of see what was happening and who it continues to affect the most. Our death data, we're actually going to be switching to rates as well, so that we have an easier time comparing subpopulations. So it's more comparing apples to apples. So we're continuing to do that work. Like I said, we're looking at making a more robust data section, health data section, and including a couple GIS folks. So I'm hoping to hire individuals that really specialize in visualization that can help us with the dashboards. We are looking at adding several additional tabs. One would include COVID, flu, and RSV. There's a lot of misinformation out there about COVID is no different than influenza, but when you put them on a graph together, you can see there's a significant difference. And then another graph with those three respiratory illnesses and deaths. And then lastly, the wastewater data we'll have on here. So we'll have two different graphics, one with concentrations for the two sites here in Douglas County, and then we'll overlay that with some hospital data and variant data as well. So that's the update on the dashboard. I do apologize. It is taking a little bit longer. But again, this is when people go to the dashboard, this is where they'll originally land. And we'll have these cards, and they'll be able to select what condition it is they want to look at. I don't know if I showed you this last time, but we've also started to include all of our other GIS dashboards on this homepage as well. So restaurant ratings, air quality, etc. Yeah. Any questions?
Just curious. You mentioned what's the influenza count compared to the past now that you have more of a regular year?
Influenza count right now is down. It's very low. I think it was less than 20 cases were reported this week. We had a really early influenza season compared to the last few years when we were dealing with COVID, likely due to people staying home more, wearing masks, being more aware of kind of that illness etiquette. But right now it's very low in our community and across the state. RSV, same thing. It kind of spiked very early in the season. It was causing a whole lot of issues with hospitals and hospital admissions, and now has returned to normal levels of what we would expect.
Okay. All right. Thanks.
Thank you. Oh, sorry.
So one last thing on COVID before we move on. Likely most of you have heard that the public health emergency will be ending on May 11th, and that's the national public health emergency. And we have received many questions about what exactly that means. I've been asked many times if that means that the pandemic is over. And I just want to caution people away from kind of the black and white thinking around is it here or is it not here? Just because an administrative declaration will be expiring doesn't mean that we don't have COVID in the community, and we still need to be vigilant and make sure that we're aware of what's happening in our communities and take appropriate steps. So I just wanted to put that out there. We are trying to put out information to the public, especially in light of the Medicaid, the annual certification process now coming back into play, which started this month. We're trying to make sure people are aware and know to go to Access Nebraska to make sure their information is updated so that they have a smooth transition. So we are aware and working toward that with our community. Moving on, I wanted to give you all a very fast legislative update, and I am going to go ahead and share this screen with you so you can see what's going to be on your Board of Health website here. Okay, good. So I had already read off for you essentially the bills that were of interest that are being followed by Friends of Public Health. My staff also really are interested in keeping up with the bills that we are tracking. So I have set this up on our intranet, but I am also going to be setting this same thing up for the Board of Health so that you are able to see what we're prioritizing in Friends, what kinds of actions might be taken, and then I'll try and get this updated as the session moves forward. Now, right now, there's not a lot happening because Kavanaugh continues to filibuster, and I did check and make sure that was still happening, and it is indeed still happening. And so that really slows everything down. However, today is the deadline for bill prioritization from our senators. It will be surprising if all prioritized bills can be heard on the floor this year, just given the length of the filibuster and not knowing how long that's going to end up going. And more than likely, the bills that are heard will be appropriations related. But still, senators continue to put in their prioritizations, and I won't have complete information on that until probably later this week, and I will update this with that information. I do know that Senator Vargas has prioritized LB 570, which is our overdose death review team legislation. So we're really excited to hear that. And then we just don't know on some of the others, and so I don't want to put out information when we don't know it yet. A lot of senators will strategize kind of when and how they put that information out. So more to come, but it will be basically on this spreadsheet that will be in the Board of Health site for you. Each of these links directly to the bill so you can see the most current language. It details who introduced the legislation, the topic, and then the position that Friends is taking and any action. Now, there are at least one bill that is more Douglas County specific that isn't on this list yet because this was more of a Friends of Public Health list. I am going to add that one bill in here so that you can see, and that's LB 613. And that one is, it is an appropriations bill, and it would appropriate funds to MUD specifically for replacement of lead service lines, which is something we definitely support and would really, really help further our lead prevention strategies here in Douglas County. So I have already sent a letter of support for that, and it will be added in here later this week. So I just wanted to show you what this is going to look like, and again, it will be in the Board of Health Google site that each of you have access to, and if you have any questions about that, just let us know. The only other update that I really have for you is that the food truck bill is being absorbed into LB 262, which is kind of the broader, it's the broader food code bill that was being worked on by Department of Ag. This is the one that also essentially takes out the requirement for the REHS. And so there is some talk on that, some amendments to that particular piece, which I should have for you in the future. But this is the time of year that people start amending bills into other bills because they still want to get their priority, or they still want to get a certain action through, but if it's not prioritized, they won't have that chance, so they work to put it in under other bills. So that's happening at this time, and I would imagine it's even more important this year since there's such limited time to hear bills on the floor. So I will keep you updated on that. That is all I have for a legislative update. Are there any questions? Great.
All right. Thanks, Dr. We'll move on to presentations. Note that items B and C have been moved to the next meeting. And just know from the conversations last time, I guess we'll, just to keep everybody there, I reiterated under the report at the end of it, but this is, I think, a third meeting in this room. We're back in this room. There's a 10 o'clock constraint, so in the administrative meeting, kind of setting up to here based on board's feedback from the last meeting, I'm going to run the meeting a little tighter, so the presentations should try to stay into 15 minutes because we got a hard 10 o'clock stop. And also, just for the public to know, the board set up at least one standing committee meeting on the first Friday of the month. That is a public meeting. By state law, it can be held by Zoom, and it will be. That's just an administrative meeting to go more in depth on department reports and anything. If people want that or follow-up, they may come from this meeting. So I'll just keep reiterating that till it gets standard from that piece. So the presentation will have a little more time. I mean, you have a little more time to play afterwards, but I'll ask you to keep it within the 15-minute round. And other than that, Teresa, if you want to come and set up, I'll try to lay the groundwork for this. Probably about a month ago, well, I might steal some of your thunder, but I'm going to try to set it up a little more.
Okay.
So U-Turn is based on a violence intervention model that most people know known as Ceasefire in Chicago. And they had 2 weeks ago brought in the international leader of the model, which is now known as Cure Violence. The distinction to me from being there, and Dr. Hughes was in the presentation, they had a meeting with some leaders around, some elected leaders to kind of educate on this. And the international leader from Cure Violence was a former commissioner of the St. Louis County Health Department. He's an MD, was there during COVID, and during his presentation, things got a little clearer. They got a little clearer to me because I did not know that U-Turn was in this realm. So basically, what I got out of that presentation was Cure Violence is a little bit in the violence intervention realm is getting a little bit into the public health realm. And so from that presentation, he had made a ask of how we could help U-Turn convert more into this. So as a basis for that, and in conversation with Dr. Hughes, this is a presentation for any of you all that may not know what U-Turn is. And then I think after they present, what I saw, and there were some opportunities, and I think that's a discussion that probably has to happen in more detail between Teresa and Dr. Hughes, but I think there is an opportunity for their violence intervention specialists to understand the public health world from our community health worker training. But I do think there's some training that they have from the violence intervention piece that is valuable to us in understanding the traumatic effects of violence from another lens. So that's my effort to set it up, and once Teresa goes through the presentation, I'm sure there'll be some questions, so it's on you.
Thank you. Good morning, everyone. We are honored to be here. My name is Teresa Negron. I am the Executive Director of U-Turn. With me, I have our Program Director, Ms. Judith Hill. I also have with us the managers for our different areas that we focus in. So we have Ron Smith, who is in charge of our street team, and George Devers, who is in charge of our school outreach team, and Tumiki Cobbs, who is in charge of our Women's Violence Prevention team. As Commissioner Rogers, I still call you Commissioner Rogers, I don't know if that's the right thing to say here. And Dr. Hughes were able to attend our meetings that we had with Dr. Eccles. Cure Violence Global is the model that we've been using since inception of U-Turn, which is going on 7 years now, I believe. And so we look at violence through a public health lens. And I don't want to steal anybody else's thunder, because Judith Hill is going to walk through this presentation so she can explain to you exactly how we do what we do. But I really feel very strongly and have always felt this way. Violence, if we treat our participants, which is what we do, as though they have a disease, and a disease has a cure. And so that's basically what we look at violence as. So Judith, if you want to come down, I'm going to turn it over to her. We're going to kind of tag team a little bit.
Good morning.
Morning.
All right, what I was trying to do is get us to the presentation mode. I'm gonna let you do that, Ms. Teresa. Do you see that? There it is. All righty. Now, let's see. There it is. Our mission, we offer support and resources. We want to break the cycle of violence. We want to break the cycle of poverty. We want to reduce violence and trauma, and we want to promote positive behavior change that is going to lead to resilience, healthier families, and a safer community. Our target area, as you can see here on your screen, it is based on Omaha Police Department data from 2014 to present. The Cure Violence model says that it is important that a community works with data, its local data. And so from 2014 to 2023, the data tells us that the area that has the highest number of shootings and homicides in our community is bounded by North Martin Avenue, South Hamilton Street, East 16th Street, and West 60th Street. Those are the communities that are in the North Omaha community. Our target population are adolescents and young adults, ages 12 to 25. We've actually worked with individuals younger than 12 and over 25 years of age. And again, primarily from our target population. A lot of times people say, why not the whole city? Because data says in order to be able to affect a change, you have to be able to limit your scope to where the greatest need is at. Here's just a very quick depiction of our service delivery model. We have behavioral health and referrals, our women's violence prevention program, trauma response at CHI, violence reduction, youth prevention services, employment assistance, and then our community engagement. What makes U-Turn different? Number one, we believe that we are a movement. We are not, there's about 13 of us, 13 individuals are not going to change the historic problems that we have in our community with violence and our young people. So we say that we lead a movement, and our responsibility is to present ourselves to the community in such a way that they understand what's going on in our community and that they recognize that they have a role. Our strategies are interruption, suppression, intervention, prevention, and education. I didn't know I had gotten creative with all of the changes here. So anyway, we believe that a community, that youth violence is a key indicator of the health and well-being of a community. You won't hear that said often. So when you think about that, what are the health issues of our young people and how does it reflect on our city? Oh my. We believe that we must approach violence prevention in a new and a different way. And as you've heard, we believe in the Cure Violence model, which says that you must treat violence the way you would a health epidemic. Violence is contagious. It affects men, women, and children in our community, and we believe, and the Cure Violence Health model has shown that it can be cured. We believe that the Cure Violence Health model that it works best when we focus on behavior change. We actually work with our participants to get them to, first of all, understand who they are, why they are, what their goals and what their aspirations are, and then we begin to focus on those behaviors that are having a direct impact on the demonstration of frustration, of anger management, and all of those things that we find ourselves dealing with. This is not new to you. Nationally, homicide remains the second leading cause of death among 15 to 24-year-olds, and the fifth leading cause among 25 to 44-year-olds. African American males are disproportionately affected by violence in their community. In 2022, there were 697 shots that were fired in the U-turn target area. Now, we understand some of those may have just been random shootings. It's New Year's, we're going to shoot off our guns, whatever it may have been. But I need you to know that that was a 32% decrease over 2021. And one of the things that we say is if we just took 1/10 of those shots that were fired, and they had actually hit someone and caused a death, we would be having a very different conversation in our community. In 2022, we recorded 12 homicides in our target area. That was one less than it was the year before. Understanding the Cure Violence model, we use this model, and here's the strategies that it focuses on. Number one, it says identify the highest risk, those individuals that are most impacted. It says that those are males and females, 16 to 25. They're weapon carriers. They're members that are affiliated with or a member of a gang, a clique, or a crew. One of the other strategies, they may also be a recent victim, someone who is associated with someone who's been killed by gun violence, someone that's been recently released from prison, someone that has a prior criminal history that involves violence. The second strategy that we use, we hire credible messengers. We believe that the success of our program comes when we hire individuals who have life experiences that mirror the young people that we're talking with, so that when they say, I can't, they're looking at a young man that says, yes, you can. When they say that there's no way that this can be changed, you're looking at a woman that says, yes, it can, because it changed in my life. We detect and we interrupt potential conflict. Our goal is to get in front of what is happening in our community. Now, you may not see this on the television, you may not hear it a lot. The reality is we are connected with the young people in the community. They often call and tell us what's happening, and it allows us to be able to say, you know what, this individual and that individual are having some conflict. We need to get out in front of that, because that can potentially become something very serious. And our team, they are excellent at doing that. We mediate conflict. We are all we are approved state of Nebraska basic mediators. And so we sit down with individuals either at U-turn, in the community, with parents, with young people, and we say, let's talk about it. Let's lay out what the issues are, and let's put together a plan of resolution. We talk about how we identify the highest risk. Our treatment plan. First of all, we help young people to come up with their plan. We don't develop it for them. What do you want? What I can tell you is that young people in our community want the same thing that our children want. When you talk about what is it you want, they want success. They want to be able to be good citizens in our community. Then the question is, how do we get you from where you are to where you want to go? That's where we begin to talk about behavior change, and we work with them through our case managers. We want to take a closer look at how we treat youth in violence. Really, I'm thinking about that 15 minutes. I'm going to make this happen. We use our evidence-based model program. How do we treat? When you talk about what is the treatment, parents, guardians, schools, community-based providers, employment programs, faith-based communities, law enforcement, medical and behavioral health providers, key community stakeholders, you are all a part of the treatment. I always say that Omaha, we are blessed. We are a resource-rich community. We have funders that support the work that we've been doing in this realm for a number of years. All of that is important as we begin to try to treat violence in our community. And we talk about the evidence-based model. We also have a women's violence prevention program. Oftentimes when you hear about violence in our community, you see young men, young African-American men, young men of color. I need you to understand, and I think most of you know, that our young women are becoming more and more involved. And so we have a program that focuses on violence against women, be it domestic violence, intimate partner violence, sex trafficking, or gang violence. The reality is that many young women in our community, less than 18 years of age, are involved in something that is related to sex trafficking. That's not what they call it, but that's what it is. And we spend a lot of time working directly with them using the same model. What is your plan? Where are you? And where would you like to go? The next strategy is to mobilize the community. We spend a lot of time doing meetings like this, talking with service providers, talking to parents, talking to whoever will listen to get them to understand that they have a vital and an important role in changes in our community. We distribute lots of educational materials. We try to make sure that the materials look like the individuals that we're working with. Whatever it is that we can do to begin to share our message, that's what we do. Community engagement, talking to leaders, community residents, having block parties, whatever it is that we can do to let this community know that together we have a responsibility to say that we will not accept violence in our community and that we are committed to making a change. Again, a lot of the awareness that we do. At this point, I'm going to invite Ms. Teresa, our executive director, to come back, because what we know is this is a wonderful story. Love to talk about U-turn, but the reality is the data tells the story. I had someone to tell me, Dr. Magda Peck, who formerly worked at the University of Nebraska Medical Center. I hated data. It just seemed like it was such a headache. And she said to me one day, she said, Judith, data tells a story. I'm a writer. Oh, she sold me. And I'm telling you, I love it because it allows us to see what we've done, what we can do better, where we can go from here, and the types of changes that we can make. Ladies and gentlemen, thank you so much for allowing me to spend this short time with you.
Okay, let's talk about some numbers. So the numbers that we're showing are just from July to December of 2022. I believe that Dr. Hughes and Commissioner Rogers have seen some of these numbers from Dr. Eccles, but this is the U-turn program data. So we had 62 program participants that we served in that time period. 93% of the participants were African American, 57% were male, and 43% female. 45% African American, 35% Latino, and 5% white. 22 were enrolled, they were at medium risk, 40 enrolled were high risk, and we met with 500 plus students. And I just want to say something about the medium risk and high risk. What we look at is we're trying to work with the highest risk of being involved in the gun violence and gang violence. So that's our focus, but we also know that there are some people and participants that we have that are not at the highest risk level, but they're headed that way. So we really do focus in on that as well. Our team responded to 40 violent incidents in the U-turn target area in that time. 9 homicides occurred in the U-turn target area. We had 510 hours of interruption. 37.5% had a recent history of conflict, and 12.5 had a long history of conflict. So as part of our case management, we call it intensive case management because it's not like the social services type case management. It's a little bit more stringent and, for lack of a better term, in your face. But we had 251 norm change hours, which is we're really trying to focus in on changing those norms that we as a community accept. We had 1,201 behavior change hours, 152 total community-based referrals, 80 plus one-on-one interventions with youth detained at the Douglas County Youth Center. We really, our team went out when we received training so that we could get into the youth center and be able to meet one-on-one with anyone that's in the youth center on a gun charge. And out of that, we do have some of the detainees that are now participants in our program. So we have done evaluations. We've done them yearly. The evaluation findings are in the prevention work, 65 street outreach events. We had 28,861 community residents and service providers that have attended these events. We've had 12,207 hours of participant engagement, and 77.2% of our participants contacted U-turn before a conflict escalated. That's, to me, that's one of the biggest things that I think people don't understand. For a person to contact somebody that is their case manager before they'll go out and do something is not normal. So the work that this team does is amazing. We've had 100 community conflicts that we mediated. So we also had, from our evaluation, there's a dashboard that talks about the cost savings. In 2020 and 2021, the cost savings was between $70 and $100 million as a result of gun violence interruptions. We had 100 firearm incidents prevented as a result of suppression, interruption, and mediation activities. I'm going to open it up. If you have questions for myself, my team is here, and I think I'm going to have them come up and respond to any questions that you might have. Is that okay?
Sure.
Okay.
While everybody's thinking, let me state, so one of the reasons that I think we asked for the presentation, because I can't remember his name, but the director, Dr. Eccles?
Yes, Dr.
Okay, yeah, the conversation that was had with Dr. Eccles, and at least I saw it clear from there, was the point Judith made about the data telling the story. I mean, at the time, and this is the point, this is a timely day, because the guy that came up there, new epidemiologist, that's the point I said we needed to make contact, because what I saw in that room was they have a set of data through some systems, and I think the opportunity for us to be able to connect with them, with the epidemiologist, and be able to work that and tell their story is an opportunity for us, not only on, to me, it's a post-COVID story in regards to everything that happened COVID-wise and that arose. It's a health department, another avenue about what we wanted to get into with the Office of Equity, some things that have come up, and also some of those other social determinants of health that come through this. So the hope is eventually, as Teresa and Dr. Hughes talk, that role of the epidemiologist becomes a little more pertinent to you all. And I think there's a conversation that needs to happen there when he gets settled, to be able to go there and look into it. And I think there's a back and forth story and a data exchange that can happen with us to help us open that up. But also it adds a different framework than the police chief telling the story from a criminal justice angle. It adds another element of the public health director telling it from some of the other effects and other things that happens. I do know that some of the things talked about there were, I think it was talked a little bit about, there's a growing number of, and I think you all probably are involved in a lot of that, but a lot of the discussions happening with more so the local school system about what they're saying is the increased number of guns coming in contact. And that had a bigger discussion about, that traumatic effect. You look over, as they stated, the work that's going on in the youth center. And there's a degree of kid there that has probably fired a firearm and has an offense. That's another level, but there is a number of kids there that are in possession, didn't use, and a lot of that, at least from what I'm told, from the information that we're acquiring, is that a lot of it is for protection. And so you cannot, then there's probably other traumatic effects that come from that. So there's a story to be told. I think we just need to get in the room and figure out how we make it go and work. And I think, as I was saying, there is a level of, I think, community health worker training that we have for them to open up the public health world, and vice versa for them in that world. So I don't know if there's any other questions. That's more what I'd glean.
I just, on the face-to-face meetings that you have with participants, does that occur in your building or in the home, or?
It can occur both. Usually we out in the target area, so we meet our participants at their home. And sometimes it's just good for us to build camaraderie with the participant. I might have them come to the office and meet George, meet our executive director, meet Ms. Judith. So most of our work is done vice versa, 50% in the street with them talking and having a conversation. There need to be some confidentiality, then we might meet me at the office.
Look, so can I ask this? I want to assume, do most of the board members know what it's a prettier term. You know what the term credible messenger means? Okay, we good. I just want to make sure everybody's on the same list. All right.
had a question. You put one of the high-risk groups were victims. Are you guys able to get in and reach out to them in the hospital or shortly after? 'Cause I know my sister's experience, at least in Kansas City, was like she takes care of one knowing that she makes them better, and sometimes it was escalate the violence. They were stealing evidence and stuff like that. So
Usually in a case like that, we get phone calls from partner agencies. Beto Gonzalez, that works with the hospital program. He'll reach out and we'll collaborate on how we can help that individual with some wraparound services upon their release.
As the victims and participants are identified, I would assume due to the trauma that they've experienced throughout life, they have some mental health issues. How receptive are they to help, and where and how do you typically refer for that? Or is that done in-house, et cetera?
We have a lot of partnerships with therapists, and also our therapists look like us. Some of our participants are like, no, I don't want a therapist. But when they come to the office and they be like, that's a therapist? Okay, so then they start meeting with the therapist. We also have a good partnership with CHI, and CHI send us referrals, and we meet the client where they at. Some can be in the hospital at the aftermath, and we do a partnership throughout the time with all the agencies that bring referrals. Project Everlast, we have so many referrals, but we do meet them where they at.
Are you essentially on call 24/7?
Yeah, 24/7. If it go down, we there.
Yeah.
If it's in the community, we there. That's what we do.
Absolutely.
I could be at home, when we first started the program, me and George can attest this, whether it's Tamiki. Something go down and we know we got to be there for our participants.
Yeah.
A comment and a couple of questions for you guys. First of all, thank you for your passion and your commitment to this work. I can really hear it in your voice, and I can see it in your data as well. Question in regards to referrals. Are parents or family members able to refer a participant, and how that process looks like? And then also, what is your program? When you talk about your program, how long is that term, and how do you measure success for a participant in your program?
That's good.
Okay.
Which one you want to take?
I'll take the measure of success.
Go ahead.
Okay, I measure success. It can be simple. I had a participant that showing her empowerment as a woman. She didn't want to go anywhere without permission. She didn't want to get a job. She has been at Hilton for over 6 months. And that aha moment, when you eyeing a person that abused you, and it feels better to be empowered and working, that's success.
So, and also referrals. People can refer their kids, but we deal with the highest risk. We don't deal with at risk. We got other agencies that deal with at risk. Just because you got a bad little boy at home, you call U-Turn, 9 times out of 10, he has to meet our criteria. Those components Ms. Judith's talking about, carrying a gun, 16 to 25, just got out of jail, out doing community violence, hooked up with a gang. Those factors give us an understanding of this is the individual we want to work with, the higher. But when the parent calls us and give us a referral, we take the referral, we process the referral, we talk to the kid. Your kid don't have to work with U-Turn. We don't make kids work with us. They gotta want to work with us. So mom can't say, well, boy, you going to work with U-Turn. That probably won't happen if the kid don't want to work with us. So through conversation and through our strategies and through our risk factors, we make the determination that they're eligible to work with us.
Just to piggyback off measuring success, and I could reference to a young man I was working with and still working with, known gang member in the community, known gun carrier. With the relationship that we built through a great deal of time, he went from carrying his gun every day to working, building a healthy relationship with his son, mom, to calling me one day, FaceTiming me one day, saying, look at this guy. You know what I'm saying? He's slipping. The old me would have had him. The old me would have got him. But you know what I'm saying, I'm on something different. That's a measure of success that ain't gonna be talked about in the public.
Let me just piggyback on that. You know, I tell kids, you know, we're a violence prevention organization. We interrupt, suppress, we get involved. Can't put a time limit on that. You take a 16-year-old that's been gangbanging since he was 10. He has 6 years to develop this behavior. It's probably going to take about a good 4 or 5 years to deprogram him to where that behavior is no longer there. And he got to walk with you. He got to be able to have a conversation with you. He got to be able to see what you're talking about, not just hear it.
What's no? Go ahead, Dr. King.
Thank you. Hey, nice to see you, George.
Yeah.
I've worked with a few of you in the community, so I really applaud your efforts. I know in the past you've worked with Dusk to Dawn as a part of your programming. I just wanted to know if you're still working with them and how beneficial do you feel like that program has been, kind of related to relapse of the kids that are coming out of that program and working with you all.
Off the top of my head, Dusk to Dawn, we did it. Matter of fact, one of our directors did it, Stuart Gaddings. He did Dusk to Dawn. Very impactful. I'm still talking to some kids at the Boys and Girls Club that was impacted by that. When they saw the bodies, they understand the autopsy. Some of them make some decisions. We're still collaborating with Alberto Gonzalez that's up there now. They're doing a program right now where we come in, they can refer, hey, this guy's got shot or whatever he's going through, the trauma. All of it's trauma. All of it's trauma. So if we can help with that, we will. I know that we work with him personally, but when it comes to the Dusk to Dawn program, very effective program. I don't know. I can't really speak on it.
I would just say that I know they have their program up at the UNMC now, and I think they're primarily doing Dusk to Dawn internally, but we still have a relationship with them.
Yeah. What's the caseloads y'all carrying? I'm just interested.
We carry 15 participants on our caseload. As managers, we carry 8. So
okay.
I got 4 guys that carry 15. So we carry. Right now, we're able to carry 60. I think George got how many?
From the staff totally, you can have 60.
We can have well over 60 participants.
Managers have 8.
Yeah.
Yo, go ahead, go for it.
Basically, our outreach case managers, they
get to the mic though.
They each carry a caseload of 15
okay.
because they're doing intensive case management. They have to have no less than 4 visits a month. You can't say that you're in a relationship affecting change if you don't see a person at least 4 times a month. So I believe that right now our staff at its current, we have 10. I believe that we can carry a maximum right now of 120. We have 6 slots available that we're still opening with each one of those individuals that come on. Again, they will each carry a caseload of 15. There are other organizations that carry a little bit larger caseload, but what we have found is that if we're going to be most effective, we have to be able to spend the time. And what we don't want to find ourselves in is that we have a caseload of 30 and we're doing a little bit of something with everybody, but we're not spending that intensive time that it takes in order to be able to make the change. There was also a question asked, what is the average length of time? 18 months to 2 years. But if you, and the beauty of our program is, at the point you say you no longer wish to engage or you've graduated, we close your case, but your information never leaves our system. So that if in 2 months you decide I need to come back, I've changed my mind, we simply go into the system, open up your caseload, and we continue with you. So we're going to walk with you as long as you choose to walk with us.
Okay. You all know. Oh, go ahead.
Is there a matching process? So, excuse me, when you get a referral of identifying who's best to work with that particular youth or young adult, like is there a matching process? Do you try to match females with females, etc.?
Yeah, we get together as managers. We had a conversation, especially when we dealt with the youth center, who would be the best fit for a kid. So me, Tamika, and George get together. Say you got a kid that lives down in the bottoms. I don't know if y'all familiar with the bottoms. That's lower North Omaha, 16th Street. Then you got a kid down there, but we know one of our workers is familiar with that kid or either that area, then he would probably be best suited to work with that kid from the youth center. and vice versa when it comes to dealing with the ladies. We sit down and collaborate on who's the best one to work with, and usually we get it.
Hey, Teresa, what is I just gotta ask you. So, on a related matter, how close are you to being staffed up with the county staff?
We are short 5 people. So,
But I mean, particularly with that money that from
just
the
one.
county's grant. Are y'all staffed yet?
Yeah, just one.
One.
We're down one street outreach person.
Okay. Okay. All right. What is there anything that I may have missed that you all think that I may not have TikToked to kind of help transition you all with the other public health piece? Because like I said, from the meeting that we had with Dr. Eccles, you all need to get immersed into the public health world. Did I miss anything, or is there something else that we need to work through to get you all to kind of connect that dot all the way?
I don't think so.
Okay.
I would only add 2 things, and that is the behavioral health piece is very important to the work. I think it was Tamiki who talked about that. We can't force anybody to do anything, but we definitely recognize that if you don't change the behaviors, that it doesn't matter how many after-school programs you have, it's the behaviors will continue to show up. So the focus on behavioral health is key in the work. The other thing I did want to make sure that we mentioned, if we did not, is we don't just work with our participants. You see mediations, they get phone calls all the time from people who aren't our participants, but they have built a relationship with them. So I think that's important to talk to, not just what we've presented with our participants, but also what we've presented with just generally having good conversations with the people they've built relationships with. So.
Okay.
Anything else?
No. But hang around, because I got a question for you afterwards.
Okay.
Seeing no further questions, thank you all. We hope to make this connection work, particularly with the epidemiologists. Item 7 is the department reports. Per the board's request, we got them a week earlier. Note, when we had the administrative meeting, the conversation with Dr. Hughes, I think she's developed a form. I saw it. There was a 2-page layout. So I think if we can give them time to convert, but you got the reports there a week ahead, and I think they're going to be converting to get it standardized, to get something in that respect. So we do have some time. So if anybody's got any questions on the reports, you can ask them. If not, we'll go into them. If you have some new questions that may have come out of there, like we said, that first Friday of the month will be that standing administrative service committee meeting to go after some detail. And if you have any questions, please submit it, and we'll make sure we go through it from there. Again, just reiterating, we've been in conversations when we move back here as the new home to have more space, more accessible to the technology. We're still crafting, working through the agenda to get us out of here by the hard 10. So we're good this week, make the adjustment. So if there's nothing else from anybody else or any other board, go ahead.
I just have a procedure question for the upcoming administrative committee meeting. Will Phil then send out that link, since it is a public meeting, or how does that get communicated out?
Yeah, we'll have to, that's why, let me reiterate it. If somebody's we'll have some topics, but if somebody's got some topics to cover, let us know. They'll go in depth, so there'll probably be limited topics to go into for a hard hour, but that operates just like a public meeting. So the link will be available. The agenda items have to be noted, and per the legislative change, we're not taking action, but the committee meetings can be done virtually. We can't do these big meetings virtually, but those can be.
And the plan, I'm sorry.
Go ahead.
The plan is for that new report template to be in place April. So the next one you will say will follow that template. just depending on the needs of each of the sections, we had a little bit we needed to flesh out and discuss before we really operationalize that. So that'll start in April. And then, yes, we will be sending out a notice similar to what we do here for this meeting.
See no questions. Is there a motion to adjourn?
So moved.
Motion by Weiss. Is there a second?
Second.
Second by Wilkin. Roll call.
Yes.
Yes.
Yes. Yes.